All right. Good morning, colleagues. My name is Dr. Yetunde Abioye. I'm the incidence manager for the Lassa Fever Technical Working Group. I'll be moderating this webinar series, and you are highly welcome to this meeting. So sorry, we are starting 6 minutes behind schedule. This was due to some technical glitches. We'll start right away now. And Charity, the next slide, please. Okay, so we'll just start with a recitation of the second stanza for the national prayer, which will take us about 30 seconds, and then we'll get into the program. Thank you. Amen. God answers all our prayers. Okay, so Charity, the next slide, please. So the floor is now open for Dr. Ladon to give her remarks, our Director, Surveillance and Epidemiological Department in the Nigeria Centers for Disease Control and Prevention. Ma, you have the floor.
Okay, good morning. Can you confirm you can hear me, please?
Hello.
Yes, Ma, we can hear you. Please go ahead.
Okay. Hello. Apologies. Good morning, everyone. The video is disabled, so I won't be able to on the video. I would like to extend a warm welcome to everyone for gracing this inaugural webinar of our Lassa Fever Readiness series. Most especially welcoming all our guest speakers and the esteemed subject matter experts, as well as the seasoned clinicians that currently they have over 2 decades of experience in managing Lassa fever cases at the Irrua Special Teaching Hospitals. We appreciate you for joining us and also for your willingness to share your wealth of knowledge with us as we work towards ensuring that we achieve the national target of the case fatality rate, which is having a case fatality rate of less than 10%. It is imperative that we all stand ready and ensure that we respond during the upcoming 2023-24 Lassa fever outbreak season, both at the community as well as the treatment center. With this said, I would like to apologize on behalf of the chair of this webinar, Director General, who is supposed to deliver his opening remarks, but currently in another meeting. He will be joining us much more later. And at this junction, I would like to hand over to Dr. Lois Olajide, who will be taking over the moderation as well as the remarks from me. Apologies as well. I have to drop and join another meeting. Thank you, and you're all welcome.
Thank you so much, Ma, for that opening welcome remarks. And thank you so much for your goodwill as well with regard to the webinar. Over to you, Dr. Lois, Ma.
All right, thank you so much, Head of Department, Surveillance and Appeal, and thank you, colleagues, also for joining this call. So the opening remarks has been given by the Head of Department, Nigeria Center for Disease Control. So without taking so much of our time, as I know that we're all quite very busy, I'll hand over to you, Yetunde, to continue the moderation. Thank you, and hope.
All right, thank you so much. Charity, please put up my slides. All right, so good morning, colleagues, once again. Okay, thank you for that. So I'll be giving an overview of the situation report for Lassa fever so far in 2023. And just a very brief background on what Lassa fever is. Discovered in a village in Lassa town in Borno State in 1969. And this was following infection of this virus from 2 nurses who unfortunately died from this. Before then, the characteristics of the virus was already known, but it wasn't isolated and known to be a new virus. So this was what led to it. And then over the years now, we've had established annual outbreaks, especially in Nigeria, and it's also endemic in other West African countries. We have reports of cases every month of the year, but we have a peak between December to May every year. And then the reservoir for this is the multi-mammate rat Mastomys naturalis, and we have a transmission from these rodents to humans, and we also have established humans to human transmissions, which is well documented in our healthcare workers and also hospital-acquired infections, where we see people coming down with this virus who were not initially sick due to an outbreak within. It affects both male and female and all age groups as well. But we'll see later that also this actually affects the very active population, which is 21 to 30 years of age. Next slide, please. So this generally just gives an overview of the epidemiology of the outbreak over the years since its discovery in 1968, and then some of the data that we've also had seen a bit of record over the years where we have documentation of this virus or infections or outbreaks rather. But you can see, as you can see, the red lines have been increasing, showing that you have a higher number of outbreaks across the different states, because this is actually looking at outbreaks in states. We know some states that we kind of term our high burden states, and some are beginning to emerge as also, newly high burden states like Nasarawa, Plateau, Benue. But then the regular ones that most people that are in the field know is Ondo, Edo, Ebonyi. And then now even Bauchi is now one of our high burden areas as well. And then we also have reports of cases in states that have not been reporting, like in Port Harcourt. We've had a confirmed case. So it's been increasing. And currently we have outbreaks of this disease across 28 states and 113 local government areas. Next slide, please. So this is just giving us a general overview of this situation. And so this year we had a very early peak of the virus. We had an early peak of the virus. The first week we had a report of a case, and this was following the confirmation of a case in healthcare workers inspection. Usually the report of this case or the outbreak of the Lassa fever season starts when there is an associated healthcare worker infection. So this was the TWG, National TWG for Lassa fever was notified on the 6th of January this year. And like I had earlier said, the predominant age group that's affected 21 to 30, it affects all age groups. It affects both male and female, and the ratio is 1:9. So from week 1 of this year to week 43, we've had, unfortunately, 188 deaths amongst 1,107 confirmed cases. And we've also had 7,966 suspected cases across 28 states and 113 local government areas. So we had, a very early onset of the outbreak compared to other years. Like you see in the red line showing 2023, there was a sharp peak of the outbreak this year. We had a lot of confirmed cases, and this also, we also saw that the EOC was also activated for a very long time compared to other weeks. We de-escalated on 22nd of June. Meanwhile, other years we de-escalate earlier. So we've also deployed national rapid response teams using a One Health approach to 6 states. We've had the Lassa fever research colloquium to guide research preparedness and response to the outbreak, to look at contextual issues. How do we get to resolve these issues? This was done in early May. We've also had a workshop with the support of CEPI on Lassa fever vaccine development. And we've also had the coordinating minister of Health and Social Welfare has established the effective vaccine team for Lassa fever. We know that's going to be a good game changer. But before it comes, this workshop is targeted to make sure that we are ready to act as clinicians, treatment centers, the community. What do we need to know to make sure that we are ready to act? We've also had the pilot of the Lassa fever clinical management fellowship, and we are also hoping that with the support of our partners and everyone, whether from Ministry of Agri to Environment, NEMA, Red Cross, how do we also make sure that we have more clinical management fellowships? Even though clinicians are leaving the country, the ones that are ready to stay, how do we make sure that they are protected and we don't lose them? because so far we've had 51 healthcare worker infection, and unfortunately some of them have actually died from this. So we need to make sure that we protect the clinicians that we have, and this fellowship is a very good avenue to make sure that we actually have, we prepare them properly to act, and also make them to prevent themselves from coming down with these infections. So we definitely need more support in that. We believe before the year runs out, hopefully we get funding from our partners and our other colleagues. We also provide offsite support to states through our various pillars of the TWG, which we are going to see. Next slide, please. Through phone calls, we've been able to do that. So during this outbreak and other outbreaks that we've done, the National Lassa Fever TWG was actually established in 2017. So the structure, we use a One Health approach. We have colleagues across the different areas. We have different pillars. So we have coordination, we have surveillance and epidemiology, we have case management and psychosocial support, we have laboratory, we have IPC and safe burial, we have risk communication, logistic research, vector control and environmental sanitation, and food safety. So as much as possible over the years, we've tried to work with colleagues to see how we can actually bring down the burden of this Lassa fever, which is endemic in our country and other West African countries. How do we make sure we control, the spread and the impact of this virus within our borders and outside our borders, so we don't end up exporting the case? This is part of the reason why this Lassa fever webinar series was created. So we are hoping that we'll strengthen coordination nationally and we'll also strengthen coordination across the state. Next slide, please. So this just shows generally our surveillance and case investigation. I mean, we are moving from the paper-based to electronic forms, but then we also know that we still have a way to, you can see the manual entry by the left-hand side to see how we can coordinate to our electronic IDSR platform, which is SOMAS. And this has been done across the state. We've deployed SOMAS to states, but then we'll also be rolling out SOMAS to the healthcare facilities, treatment centers, to see how we can be able to make sure that we get data across from our local healthcare facilities, the local government area, the regional or state, and through the Nigerian Centers for Disease Control to also communicate with other international organizations like WHO, ECOWAS, and our regional ECOWAS, yes, body, that's the West African Health Organization. So even through our laboratory networks, with as much as possible. And I know SOMAS has also been optimized to make sure that it also helps with our response and strategies. And then we also, of course, provide offsite support by calling states to make sure we have data completeness on SOMAS. Next slide, please. So for our risk communication, we've done a lot of targeted risk communication and activities in most affected space. It will also be interesting to know that with the support of Breakthrough Action, we are airing some jingles, and we're also doing a form of play to make sure we also prepare adequately for this outbreak that is unfortunately coming very soon. So we've done a lot of, human-centered design, sensitization of healthcare workers, dissemination of media contents through all our social media platforms, and also with the support of our partners and with the support of the state. Next slide, please. So our coordination and collaboration, we have, risk assessment for activation and de-escalation of the EOC, which have already been talked about, deployment of national rapid response team. We did an after-action review of 2022-2023 outbreak season, and part of the output of that was to make sure we have high-level advocacy across, every level, and that's what we are having today. Part of it is this webinar series, which will also have more. We've had media briefing on the Lassa fever outbreak, and coordination and collaboration with our partners. We are able to coordinate response activities, prepare, and also be ready. Next slide, please. So our key achievements, we've been able to review and disseminate our IPC guidelines for Lassa fever. We've had a pilot of the Clinical Management Fellowship, which we are very proud at the TWG, and we're looking for more support for that. We've also established additional Lassa fever testing laboratories, and even as we expand our laboratory network, which is part of our mandate at NCDC, we are also looking at some labs. We have zonal labs now. We're also going to establish more. We've also distributed medical countermeasures like Ribavirin, PPEs to the states. We've also sent a joint alert with CSM TWG to make sure that we also prepare adequately. This has been sent to all states, directors of public health, and also the state epidemiologists to help prepare. Next slide, please. So challenges and areas of priority for us as a TWG, the issues of workforce attrition, we can't really help so much, but we can also help in a way to control and also make sure that we are able to protect the healthcare workers that are actually still in the country and have decided not to go anywhere. We also plan to strengthen healthcare systems for early detection and diagnosis. It's also very important for states to also on preparedness and response. Unfortunately, now we don't have free treatment for Lassa fever, even though we know that it's good for present early, but then we also support the states with medical countermeasures like ribavirin free and other things to support treatment of Lassa fever. But currently, I'm not too sure if this is captured as part of the things that you can get free treatment for. But then we try as much as possible to do so. It's also important that states also, because the communities, outbreaks occur in communities, and these communities are within states. So if the states are also able to contribute to also help to make sure that, people actually have free access to, better healthcare facilities and also free treatment for Lassa fever, I think this will go a long way. So that's one of our major challenges. And of course, now, thankfully, the coordinating minister has also inaugurated a team for effective vaccine development for Lassa fever. But then this is a long-term solution to the ongoing challenge of Lassa fever in the country. Currently, our case fatality rate is at 17, and we are planning to have case fatality less than 10%. So a single digit, but we are still far away from this. And then we also want everyone to adopt the One Health approach for the EOCs, or whether responding to diseases, especially like Lassa fever, while we are here today, we need to adopt a One Health approach whereby we have a multi-sectoral, multidisciplinary approach to respond to these threats within our borders. Not one single sector owns One Health. Not one single sector can respond to Lassa fever. We need everyone. How do we do ecological control of these rats, while we also make sure that we are protecting the environment? How do we make sure that the healthcare workers are protected? How do we make sure that people are able to respond early to present early, rather, for early better treatment outcomes? How do we make sure that we also carry along our traditional healers or herbalists? How do we make sure that everyone in the continuum of care knows what is important to do at every point in time, so we don't have people dying to this scourge? Especially, it also affects the very young population, 21 to 30 years, and this is a very active population that will contribute to the GDP of the country as well. So next slide, please. So of course, these are our key indicators, and we're trying as much as possible to make sure we reduce healthcare worker infections, because we need the healthcare workers to be safe, to be healthy, to be able to treat people that come down with this disease, which is endemic in our country. So, and it's constantly spreading. You can see from the map, we have our high burden areas, but every state in this year has reported a suspected case of Lassa fever. How do we make sure we have confirmed cases now in 28 states and 113 local government areas? How do we make sure that we don't, the zones of impacts of this virus doesn't keep increasing? Because with the rate at which we are going, in the next outbreak, we might probably have confirmed cases all over the country. And this is a very growing concern, because if we are not able to control the spread and impact within our borders, we might likely be exporting it internationally to the UK and other countries. And this is not a situation we want to be dealing with. We need to, if we as Nigerians face the highest burden of this virus, we need to make sure that all hands are on deck, use a One Health approach. Our clinicians understand. We need to work with colleagues across the ministries of Agri and Environment to see how we can reduce the spread of this virus. Next slide, please. So together, we can reduce the CFR to a single digit. Thank you so much for listening. And yes, thank you so much. All right, so can we have the next presentation? I think Charity. I don't know if the DG around now. If our Director General is not around, I think we can go on to our next presentation. Okay, I think, so this takes us to the next presentation by Professor Ruben Ifedi, who is the acting CMD for ISTH. Over to you, sir. Professor Ruben, you have the floor, please.
Okay, yeah, thank you. Good morning. I want to thank you, Yetunde, for your lectures. I really appreciate your One Health approach, which is collaborative, multi-sectorial, and transdisciplinary approach. I'm Ruben, FAD, from Irrua. The topic of my discussion is treatment center readiness, and I will use this outline to rush through the presentation so that we can take something home. I will look at introduction, what is treatment center readiness, why is organizational readiness important, what are the factors affecting readiness and responsiveness, then what are the key components of treatment center readiness, then I'll conclude. Next slide, please. We all know that hospitals and other health have to play a critical role in national and local response to emergency, such as communicable disease and epidemics. And Lassa fever is not left behind. Yesterday, I already look at the updates of Lassa fever in Nigeria. This year, where we have an early peak in January this year, we have over 188 deaths. Is something we do not really appreciate. And over 75% of these cases occurred in 3 states, Edo, Ondo, and Bauchi. Next slide, please. To guide this presentation, the objective is to guide the hospital management and everybody are involved in preparing for epidemic like Lassa fever, whether in the private sector or non-governmental agencies. We all really have to be ready, because I believe a wider audience are all stakeholders across many sectors, including government, health authorities, financial institutions, disaster management organizations like NEMA, and local suppliers. Next slide, please. So the overall goal is to reduce the impact of a pandemic in our environment. What do you mean by organizational readiness? It actually indicates the relationship between people, processes, system, and performance measurement. It actually requires synchronization, coordination. With no implementation will be successful. Next slide. It also means motivation combined with capacity. The readiness has often met a psychological state. These represent a state of commitment to a particular course of action. So that is why this topic is very important. So the ability of every organization or agency to deliver and support the availability and use of intervention for improved global health depends on their readiness to do so. In fact, studies have shown that when you prepare for any disaster or mass casualty incidents, you are more likely to succeed in the response to some diseases. Several studies elsewhere in Nigeria and elsewhere. Next slide, please. So there's actually steps for organizational readiness. What is your vision? That is step one. What are the structure and key roles to bring that vision to our life? What are the competencies for that key roles? What are the assessment of what? Current bench strength, gap analysis, gap resolution, and sustainability. These are the steps for organizational readiness. So remember, our topic is treatment readiness, treatment center readiness. So if you have all these as your step, most likely your treatment center will be ready. Not only for response, because preparedness planning and testing of preparedness actually critical to your capacity and capability to respond to any outbreak. Next slide. Next slide. Okay, let's discuss why is organizational readiness or treatment center readiness important. You will know that we have National Strategic Development Plan for the country, and we have 5 strategic pillars, of which pillar number 4 actually has to do with protection from public health emergencies and risk, of which the priority area there is to prepare for pandemic and other health emergency. So the objective for that on that pillar is to reduce the impact of what? Epidemics or outbreak. And in this case, like Oyedide said, we are to reduce our case fatality from 70% to a single digit, which we cannot do if we are not ready. So that is why the importance of this discussion. And I believe if we are really ready, we could reduce it further from 70% to something much better, because our people are dying from these diseases. Next slide. Okay, let's look at it. What are the key components of treatment center readiness? The most important one is the leadership and governance structure. I will say, mature leadership, structure, and governance create the foundation for optimal epidemic preparedness. What I actually meant by this is that you need a consistent and committed leadership that is focused on preparing a center for outbreak, especially at Irrua, where we have been plagued with the epidemics for more than 30 years. So you need a leader who is not only matured, committed, and ready to commit adequate resources and implement many relevant evidence-informed policies plans to move the treatment center forward, and also try to prepare and also respond to the epidemics. Next slide. So we have the goals of leadership, which I've already discussed already. Next slide. 5, to be prepared to face any risk or emergency, a hospital should have in place a permanent, that is number 1 requirement, a permanent hospital emergency committee responsible for developing the hospital emergency risk management program, of which emergency response plan is an essential component. This is one of the most important things you have to do. And the membership of that emergency committee are, next slide, to include representative of the hospital main activities, including administration, medical, nursing, emergency department, infection prevention and control, pharmacy, laboratory, security, engineering, maintenance, human resources, laundry, food, services, cleaning, and waste management. They are all part of this committee. And they are to develop, next slide, please. They are to develop the emergency risk management program. 1, they are also to establish incident command group, which is responsible for adapting the hospital incident management system and all hazards in the hospital. That's what they are to do. While the incident command group will develop incident action plan, which specify the tasks needed to respond specifically to the emergency. That is actually the function of the hospital emergency committee. And the hospital emergency committee, emergency risk management program, emergency response plan, incident response group, incident action plan, form a preparedness and response system that ensure the coordination of all the activity required to prepare and also to respond to an emergency. This is very, very important. If you have this management structure in place, you are more likely to be prepared and also to respond to an emergency. So how many things do we really have there? We have a committee. We develop the emergency risk management program. What does it really do? It's for you to actually look around your environment. What are those risks in the community and in the hospital? You look at them. Then you develop emergency response plan. Then form the real core people, the incident command group. You remember that yesterday is incident manager, incident command manager. That's what he really means. The incident action plan for everybody is very, very important. This is really the work of the leadership of the hospital. So next slide, please. Okay. There are some, you have to establish a list, hospital emergency coordination center, where the incident command group meets, and it could be a dedicated place or any meeting room in the hospital. Like Irrua, we use our boardroom where we meet during the pandemic, and we articulate all our problems, because you know that everybody in the hospital is actually part of that committee. But the incident command group, the members also are part of the hospital management committee. So they will look at the real issues and give out commands. That's what they really mean. They look at the action plan. If we have problem with dialysis, we have to take care of the problem. If you have problem with medications, we have to take care of that. But in preparedness, you need to start doing what's called stockpiling, making sure all those things are in place, your dialysis machines are in order, and also your community people, they are already doing your campaign, awareness campaign in the community. We are all prepared. Like what we are doing right now, we are just training, creating public awareness. We are all in preparation for the period. Remember last year, we have an early peak. We don't like it. We really know what happened because rain stopped 26th of October last year. We are still having rainfall in southern Nigeria at this time. So we do not really expect early peak this year. Hopefully, to enable us to prepare for what will really happen. Thank you. Yeah, move on. Next slide, please. Fine. These are the basic requirements. It's just a summary of what I have discussed since. A permanent hospital management committee chaired by the executive, hospital management risk management program. We have the incident command group established by the committee. Then we have incident action plan developed by the incident command group. It's a summary of what I've just said. Okay, let's move on, please. Okay, this picture just shows what we did this year. This is our action after action review. It's part of our preparation for the next epidemics. We are reviewing what has happened in preparation for the future. Okay, move on, please. Next slide. Next slide. The next slide. Okay, like I said before, this is a vision of our institute, and these are the operational units of IVEP, which is our institute, where the treatment center is located. Go to the next slide, please. Next slide. We have the laboratory, case management, psychosocial support, public health and surveillance data management unit. We have the administrative unit. We have the infection control and environmental health. This is our unit in our institute where we treat our patients. Okay, next slide. This is the hospital emergency management. This is the policy which we are testing, because I told you about leadership. You have to have what's called a emergency risk management program. This is our policy which we are testing. Everything concerning what we are going to prepare and respond, we already have it. It is documented and we have to test it, because training and testing of your policy plan is key to preparedness. And WHO actually developed a checklist or a check tools to do that, which I believe NCDC will work with our treatment centers and use it during this period to check all the centers to make sure that they're actually ready for the epidemics. Next slide, please. This is just a summary of what we did in the after-action review, and the policy orientation initiative, they are all there. Thank you. Next slide. This is the second summary. Last outbreak was characterized by about 9 like I can say, low index of suspicion, late collection of blood sample, late diagnosis, late referral, late presentation, late initiation of therapeutic measure, late dialysis support, late availability of blood products, and low financial and family support. Those were the 9 that contribute to mortality and morbidity from our action review, which I also want everybody to look at and see how to remove this late and make it early. It will reduce further reduce our case fatality rates. Next slide. The second component is infection prevention and control. So looking at infection prevention and control, just to reduce the risk of transmission of health-associated infection, is very, very important. But what really matters is for us to know the real core practices of IPC, and also to know the core practices actually what the standard precaution. We have what's called the transmission-based transmission precautions. Then we have the enhanced precaution for Lassa fever, which includes isolation and restriction in treatment center, and security. All those are enhanced transmission precaution. For the standard precaution, we already know the 7 components, which are important. But most importantly is for us to have what's called the IPC organizational program, and also we have the core components of those programs, which include the existence of a program 1, We have evidence-based guideline for taking care of that. Education and training on IPC. Then we have laboratory surveillance for HI, that is a hospital-associated infection, which is also important, and use of multimodal modalities to prevent infections in the hospital, and enable environment, which actually consists of two related things on patient staff and workload and bed occupancy. Those are what make up the IPC program. So you need to have in place all that, a comprehensive program for IPC, because it's core. It's a core component of what? For preparedness. So you need to put all those things in place if you don't have already before. But if you have, you strengthen it to make it better. Next slide, please. Next slide. These are the basic requirements, like I've said already. So we move to the next slide. Next slide. Okay. An overall emergency response plan, which is part of the overall hospital emergency management program, must identify IPC as a core function of the hospital. So who responsible for coordinating this program is an incident command group of the hospital that actually responsible for the coordination to ensure all the activities are actually carried out. The one I can actually talk about, that which is also very important, is communication and networking. I actually call it robust communication, networking, collaboration, partnership. They are part of this. Because you need to communicate as early as possible to raise public awareness of an epidemic like Lassa fever, and to provide information to all hospital occupants, and also to provide information needed to ensure as far as possible continuity of service. All that must be discussed. But what I really think about is networking, which we have done with neighboring hospitals like UBTH, FNC Asaba, especially when we run out of consumables. We need to actually collaborate with them. We need to also communicate with them. We need to network with them. We also talk about capacity. There's such capacity in case we are overwhelmed. Where do we go to? We need to also network with our neighboring hospital, primary health care. We need to network with secondary health care services in case we are overwhelmed, because it does happen. In last year, we have such a problem in terms of space, and we have to just move some patients to other areas because we overwhelm as early as possible. So communication, networking, or I call it robust communication and networking, is a key component of preparedness and what? Response. Thank you. Next slide. Thank you. Next slide, please. Yeah. Go. Human resources. That's the fourth component. What I'm interested here is education, training, and simulation. In part of readiness, you have to do what's called simulation, or test your policy, what you have in place, whether they're actually adequate, so that you can identify gaps, if form of institutional analysis, to know where you are lacking, where they are going to be a problem, or to prepare and respond in future. But you need to teach everybody, clinical and non-clinical staff, they need to be important. They are important because you need them when you are overwhelmed, when you are having such problem in terms of personnel. You need to train people. And even when you train, you need to train people role-specific roles that they will perform during the period. So this is another very important component of how to prepare for epidemics like Lassa, and we are doing that. What we are really doing right now is to stimulate our people, because a well-trained staff is more willing to respond compared to who is not trained. Actually increase motivation to do better. These are the requirements, and let's move forward, please. Next slide. Next slide. Okay, logistics. Logistics to provide, you look at it, we have what's called logistician in our hospital to provide the right resources at the right time, in the right quantity, and in the right places in order to satisfy the increased demand being made in the hospital by emergency. But what I will say to summarize this, we call it a verified and a trusted supplier, a one who trusts you. You have actually developed a relationship with, in case you are running out of many consumables, supplies, you need to have that one in place as part of preparedness. If you don't have, it's not the time to start negotiating for consumables or to start talking about that thing, we have what's called stock level we can get to. We have to stock right now. Actually, we are stocking to make sure that during the period, we don't run out of resources. So that's where this component, logistics, is very, very important. In fact, there are some questionnaire can use to assess your logistics so that you know that you're actually performing, whether you are prepared or not. It's also available in the W Workis, and it's very, very important. So pharmacy, we know we need medicine and other products, infusion, antibiotics, ribavirin. You have to know your stock level and your consumption. You know that we require a lot of ribavirin to actually manage our cases. You have to know how the expiration date, you have to check all of the expiring date, the stock level is very important in preparedness. Next slide, please. Next slide. 5, concurrent emergency. You know, during outbreak, your human resources actually overstretched. You may need to look inward. And in spite of that, does not prevent other emergency in the hospital. So you must prepare for other emergency in the hospital as well. So you have to ensure that how to prevent other essential services for another emergency. People, if somebody with Lassa can still have acute appendicitis, or without Lassa, you can also have other emergency in the hospital. You need to be prepared. We can even have a mass casualty incidents like road traffic accident, which we are located in the major artery of freight supply in Abuja. So anything can happen. So we are prepared for that. Next slide. Essential support services is important, like food and nutritional services, security, engineering and maintenance, laundry. In fact, laundry, cleaning, and waste management, always a challenge. So watch it. It's a place that will give you really problem because as we are overwhelmed, your materials and generation of waste will increase. In waste management, we have to be careful. You have to ensure proper segregation, containment, transport, and disposal is the real components of waste management. And use the RECO. Red code is meant for what? Highly infectious, which is Lassa. The yellow one is just infectious. The black one is just the general waste. So proper waste segregation, containment, and transport of the waste, and proper disposal is very, very important. So you must prepare for that because it's going to be a problem during surge. Number 10, continuity of essential health services. Is it possible for you to continue other essential services during outbreak? It's from education, it's for creation of public awareness or your immediate community and awareness, which is the hospital itself, other people, to get them involved and let them know something is coming. It could come. We don't know the magnitude, though it's predictable, but not totally predictable as we're in endemic area. So what we need to do is to educate our people in case we have how do we continue other essential health services? It's a thing you have to think about. Look at how to overcome that. Number 11, psychological and social support services. 1, to the patient, 1, to the relatives, and to the healthcare provider. We also need psychosocial support, healthcare provider. Everybody, we need that, and we prepare for it. We already have a unit of psychological and social support in the hospital. In fact, it was very, very helpful when we have the first major outbreak, 2019. Actually, 2019, we had the highest number of cases. And that's the time of COVID, and we even have co-infection, COVID and Lassa. And this plays a significant role during the process. The third one is patient management. This is where how many people respond. Case management. Many things are involved here, from dialysis, oxygen supplementation, medications, their blood requirement. Like from December, what we do is to start creating awareness for blood donation from medical students and also other students in the community, because we require blood products, not really whole product, blood products, because we have cold century machines. to help the patient, because before you do like this, you need to actually transfuse. Many people will are in need of transfusion because the what do you call it? The Lassa itself affect the intrinsic and extrinsic pathways. So, but provision of the real blood product is very important to survival. So we prepare for that. And last year, we have to analyze how many number of dialysis episodes, we call it cycles of dialysis, that was done for the total number of patients that required them, and what was the average and what were the outcome, people who did dialysis, is what we are thinking about, and also defining the threshold or the criteria for early initiation of dialysis. Okay, next slide, please. Such capacity, very important. When we talk about such, we're talking about in terms of personnel, your resources and skills. There are three things in such. Resource, that is your resources, like your consumables, your space, your personnel, and your skills. So that is the thing you talk about on that such capacity. You have all of them. If you are overwhelmed, you have enough skill to manage the cases. If you don't, what do? Do you have enough bed space in case of space? When you have increased number, it's very important. So let's move on. That is the principle of such management. Okay, let's move forward. Like I said it, everything's already here: human resources, staffing, supply, equipment, logistics. You have specific expertise for clinical area. Okay, it's very important. Number 14, how was called surveillance and research. Is a critical component, and I believe we should develop early warning system for impending incident. I believe it's an opportunity for us to actually do our research to improve, to generate better data, better decision making, and better outcome. That's what research actually meant for in this situation. Better data, better decision, and better outcome. Surveillance, excellent. That is actually really one of the core mandates of NCDC in cooperation with states and local government. And we are playing our role with the Department of Community Medicine to work with our local government and states to make sure our surveillance system is well established using different approaches. Thank you. Next slide, please. Fine. I just used this to represent factors militating against health center readiness. You can see the red color there, the readiness of health center. The first thing that will affect readiness is actually managerial and interventions. That is the first one. The second attack cycle is the community-related interventions like public awareness and the rest. Then the other factor is socioeconomic factors. Like I said, in the 9L that contribute to increase mobility and mortality in this shared outbreak, very low family and government support, low family support, relative support, play a critical role in the actually contributing to the rise in the mortality and morbidity rate. And the environmental factors, we know what is happening in the environment. The mother, we call it the mother, we call it M, which is mother, that's the environment. We can think about the real economic situation in the environment, we contribute. We talk about the rats, the bush burning, and flooding. We all increase the incident because we have two pieces in Irrua many times. We even during rainy season, we have increased risk because maybe flooding will drive the rats into the houses because they actually peri-domestic rats, which are the vectors. They are very, very important. I believe one health approach is important in actually looking at all these things, how to make ourselves to be ready for the next surge, which we hope will not be so much this year if we put in.
Prof, so sorry to cut you short.
Conclusion.
Okay, so I just wanted to tell you that you have just a few minutes left. So the next speaker needs to come up by 11.
Conclusion.
All right, thank you so much,
Conclusion. Prof. What I want to do, if you don't remember anything, look at this McKinsey diagram to summarize. What is our goal for this year? What is your goal of preparedness? How strong is your structure? Are they functional or not functional? What about your systems? What is your strategy this year? Are you ready? Have you developed your strategies? What about your style? That is leadership. Do you have everything in place? Do you have your plan? Do you have the incident management group? Do you have the required number of staff and the skill and expertise? If you have this, I think you'll be prepared. Your center will be prepared for the next surge. Thank you very much.
Thank you so much, Professor Ifedi, the acting CMD of ISTH. Thank you so much for that wonderful, elaborate presentation. So this will take us to our next presentation. Just a gentle reminder, please keep dropping your questions in the Q&A box. We might miss it in the chat box because a lot of introductions are ongoing there, and warm welcome. Please kindly drop it in the Q&A chat box and we'll respond. We have a session for Q&A. So this will take us to our next presentation. Charity, please kindly help by Dr. Ekaite Tobin, a very seasoned consultant, public health physician at ISTH, and she'll be talking about strengthening linkages between communities and dedicated treatment centers. How do we make it better? So over to you, Dr. Ekaite. Thank you so much.
Thank you very much, and good morning to everybody who has joined in.
Sorry, before you go in, so you have 20 minutes. Thank you. Over.
That should be enough time. I want to start by appreciating the organizers of this webinar, my co-panelists, and everybody who has joined in. As has been said, I am Dr. Ekaite Tobin, a consultant public health physician with Irrua Specialist Teaching Hospital, and I'm speaking on strengthening linkages between the communities and dedicated treatment centers. How do we make it better? Next slide, please. Next slide, please. I'll be following this outline. We'll take a brief introduction, look at what the objectives of this linkage can be, activity flows, parties involved, obstacles to a collaboration, and then finally, how do we strengthen linkages between the treatment center and the community, and then we conclude. Next slide, please. Next slide, please. I want to start by saying that Lassa fever occurs all the way around in states with a high disease burden. And then you have this notable surge in cases during the dry season. Now, to effectively manage Lassa fever, the control measures must be implemented all through the year. They must adopt a One Health approach and lay emphasis on primary prevention at the community level. Lassa fever treatment centers are established to provide specialized care for the treatment of Lassa fever cases, and their success at this relies heavily on strong linkages with the communities they serve. Now, these community linkages are collaborative relationships that are established for the effective delivery of healthcare services and overall improvement of the health of populations. Next slide, please. Next slide, please. Now, these Lassa fever treatment center community linkages are vital for early detection and management of cases and the prevention of transmission of Lassa fever. To establish this, we need to understand what the community's needs are, who the stakeholders are, and we need to use data from the community, from surveillance activities for decision-making. All these are imperative for an effective relationship with the community. Next slide.
Professor Ifedi, please mute your mic. Thank you.
Now, what I just said, I'm expatiating now. We need to identify the community's felt and actual needs. So what are their belief systems? Who are the decision makers in homes, in households? What are the social demographic patterns as regards Lassa fever? All these pertaining to Lassa fever. What age groups are affected? We've already heard you have 21, mainly the 21 to 30-year-old age bracket. But then you also have elderly people involved. What are the work structures in the community? How do they relate to or increase the incidence of Lassa fever? What is their health-seeking behavior? You have to identify these all these, either through public health surveillance data, mini surveys, looking at the demographic and health surveys, bringing out all the data to identify where the gaps are as pertains Lassa fever. Then you need to define the goals and objectives of such a linkage or collaborations with the community. You need to map stakeholders, not only in the community, but also in your treatment facility, and we'll come to this shortly. The potential challenges.
Sorry, Dr. Ekaite, can you pause a bit? Professor Ruben, please, can you mute your mic? We are hearing some background interruptions in the presentation. Or eHealth Africa, can you help? Or anyone from Comms team, please. Okay, so I think
Okay,
we are
so
good to go.
So who are the stakeholders? Sorry, please, go back, please. Sorry, please, yeah. Then you need to identify the potential challenges to this collaboration, and then develop and implement smart plans we'll be talking about very shortly, and periodically evaluate progress towards your objectives. Next slide. Next slide, please. So what could be the objectives of the Lassa Fever Treatment Center community linkages? What would we hope to achieve by making sure that the treatment center and the communities are as close as possible relationship-wise to each other? First is to enhance the community's ability to recognize Lassa fever symptoms and report suspected cases. We would hope to, through these linkages and collaborations, improve access to diagnostic facilities for confirmatory testing. We want to facilitate efficient referrals of suspected and confirmed cases to the treatment center. So suspected cases to the holding bay and confirmed cases for immediate commencement of therapy. We want to raise community awareness about Lassa fever, and by doing so, dispel doubts and myths and misconceptions. Such a linkage would also hope to promote community-wide adoption of preventive measures and build capacity of the health providers in the community to manage suspected cases before referral. Next slide, please. Next slide, please. Such a linkage would help the public health team be able to trace defaulters, persons who are positive but yet to present themselves for treatment, as well as helping to follow up contacts. And it would also offer social and psychological support to Lassa fever patients and their families in the community, reducing stigma and fostering an understanding of Lassa fever. Such a relationship should, one of the objectives should also be to exchange Lassa fever data, whether laboratory surveillance or hospitalization data, with key stakeholders in the community, persons who need to know, persons who need to take action. Another objective would be to encourage active community participation in public health decision-making, emergency preparedness, and response planning, as well as to collaborate on surveillance activities and assess the impact of preventive measures, Lassa fever preventive measures in the community. Next slide, please. So, all in all, such a linkage, such a collaboration and connection between the treatment center and the community should aim to reduce mortality from Lassa fever, reduce morbidity, and ultimately prevent the spread of Lassa fever. Next slide, please. Now, next slide, the heading is missing. But anyway, what are some of the obstacles that would take the treatment center further apart from the community? One, the limited awareness that some communities have of Lassa fever and the services provided by the treatment center. Because when people feel that or believe that Lassa fever is not caused by rodents, but by some spiritual forces, then you can be sure that no matter what you're doing, they would run away from rather than present themselves for care. And ignorance of what the Lassa fever treatment center services are is also a deterrent to this relationship. The second is stigmatization, fear of stigmatization and fear of isolation in the treatment center. A general disbelief and mistrust of the health system, as we saw during the COVID-19 pandemic, and which we see from time to time in Lassa fever too, where people don't trust health providers, they don't trust the health system, they don't trust government. That is also a deterrent to an obstacle to the Lassa fever treatment center community collaboration. Now, the last one here on my list is geographical and logistical challenges that impede access to the treatment center, including finance. So when you have remote communities that with transport logistic difficulties, bad roads, and the rest. Even samples would not even move easily and freely to the treatment center. That further compounds the increases number of cases out there that will remain in the community because of the delays in getting results, delays in samples getting to the laboratory, delays in patients, confirmed cases moving to the community, sorry, to the treatment center. Next slide, please. So looking at this diagram, I just want to talk briefly about the activity flow between a treatment center and community. And let's not forget that the topic is the title of this webinar gives us an indication that we want to learn the experiences of from ISTH. So from the community, blood samples of suspected cases are received at the treatment center for confirmatory testing. As you would see the arrow moving from the left to the right, the community to the treatment center. Suspected cases either referred from a private facility in the community or who feel symptomatic and walk in themselves come to the treatment center and may be admitted in the holding bay but are tested for Lassa fever. And when they are confirmed to have Lassa fever, they are admitted, treated, and they return for follow-up after discharge. From the treatment center now, when they recover, they are sent back to the communities they came from to reintegrate. And if unfortunately they die, their corpses are sent to the community for safe burial. So this is the flow of activities as regards Lassa fever between the communities and the treatment center. Next slide, please. So who are the parties involved? Remember, we've said you need to look at the stakeholders, the parties that are involved in this relationship, these linkages. On the treatment center side, very important there, you see the hospital management. And the acting CMD has alluded to the importance and role, the place of hospital management in such a linkage. Because they need, you need political will, they need to commit resources, so they are very instrumental, very pivotal to the success of this linkage. Then you have the clinical teams, the doctors, the nurses, you have the public health team, the straddle between the treatment center and the community. But you also have the non-clinical teams. You have the medical social work, PRO, admin, finance, to mention a few. And on the side of the community, you have the community groups, you have health facilities, privately owned, faith-owned health facilities operating in the communities. These are facilities where suspected cases go to, including the primary health centers, the government-owned facilities. You have traditional rulers who make decisions, who can affect the behavior of their members. You have religious leaders, people who community members listen to. You have faith-based organizations working in the community, civil society organizations, trade unions, including the patent medicine vendors and the like, traditional practitioners, public health authorities, your local government authorities, and they are there in the communities. Then you have international organizations like WHO that are interested in infectious disease outbreaks and emergency responses. So these are the partners that you pull together when you're talking of Lassa Fever Treatment Center and community linkages. Next slide, please. Now, how do we now strengthen the linkage if it's already there, or make it happen if it is not there? We need to look at two angles: community-directed actions and facility-directed actions. We will start with the community-directed actions. You want to ensure early detection and timely referral. And for this, we have training the formal health sector, both privately owned health workers from privately owned and government health facility. What are we training them on? Case definitions, case recognitions. We want to make sure that they're able to safely manage suspected cases, because these people come in early stages of the disease. They come in as other topical febrile illnesses, so they can even come in as malaria. So what do they need to do to manage these successful suspected cases? Then you need to educate them on the services and flow of activities in the treatment center. Who are the specialists that are employed in the treatment center? What cases do they manage? How does activity flow within a treatment center? You need to train them on infection prevention and control, pathways for referral of cases to the treatment center. So who do they call? Who is the DSNO? What are the contact numbers? What should the DSNO do? What is your role, in referring a case to the treatment center? What are the call lines you can dial? And then most very important, stigma prevention, right there at the community health facility. You want to address stigma. Next slide, please. And then you also need to train the informal health sector, because these are people that most of the time, these community members, they are poor. They visit the informal health sector very often. So you bring in the patent medicine and proprietary medicine vendors, you bring in the traditional medical practitioners. What are you training them on? Case recognition and referral. They need to know when to, the symptoms of Lassa fever, and they need to know who to call and how to refer a case, on how to provide information to clients. So when somebody with symptoms goes to a pharmacy, goes to a chemist to buy drugs, what information should be provided? That is very important. You need to train them on all this. It's very helpful to strengthen the linkage if you're able to distribute IC materials on case definitions and IPC commodities. Several times in ISTH, we've had to take posters to patent medicine vendors, take posters to private health clinics and IPC commodities. We've had in several instances where we share hand washing facilities, we share hand gloves to health facilities close to us. And algorithms, very important. If you have them, it helps to strengthen that connection between the treatment center and the community. If you have algorithms that these private practitioners can use in deciding on when to refer a suspected case to the treatment center. Next slide, please. And I've displayed here an algorithm that was developed. You can see the ISTH logo at the bottom there. Edo State Ministry of Health, WHO. We developed this algorithm during this year's outbreak to help private practitioners take the decision on when to send a suspected case, when to take a sample, and when to refer a case to ISTH. We found this very useful, and we got very positive feedback. What to do when the PCR test comes out negative, what pre and post test counseling to give, who to call. These are some of the documents that materials that can be shared by the treatment center and help to strengthen that connection with the community. Next slide, please. You also want to reach out to advocacy, to community leadership structures and the different groups. So you're talking about carrying out sensitization meetings with traditional rulers, religious leaders, the different community groups, the group, youth group, women group, the trade unions, and I've called out National Association of Proprietors of Private Schools, Transport Unions, Market Women, Farmers, Gari Friars, and NAPMED, because we found these people very strategic in the previous outbreaks. We found them to be very influential to their members, and they are useful groups to reach out to strengthen that connection with the treatment center. And what are we reaching out to them for? Aside from just talking about Lassa fever, the etiology, transmission, symptoms, and preventive behavior, we also want to hear from them. How can we improve services at the treatment center? Suggestions on how we can make our services more friendly to the community. We want to talk to them about community rodent control. Where do they come in? What are the opportunities for collaborating with the treatment center and with the other groups within themselves to support Lassa fever control? And we want to speak to them about stigma prevention, because these are the voices the community people listen to. These are people who can act out our policies and interventions at community level. These are people who are able to coordinate and push their members to take on preventive behaviors that reduce the scourge of Lassa fever. Next slide, please. Now, you also want to face the community, risk communication and community engagement. You want to carry out mass campaigns using culturally tailored communication on Lassa fever. You want to make sure that these are media that people listen to. So radio talk shows in local languages, open air campaigns, billboards, jingles in the different languages. In this last outbreak, ISTH collaborated with the State Ministry of Health to bring out jingles even in Hausa, reaching out to the Hausa communities around us. Then you want to work with the local government authorities to hold community dialogues and compound meetings, to have one-on-one with family heads, household heads, to talk about Lassa fever. And very shortly, I'm going to talk about what you would likely want to say to them, the talking points. Then it will be good to carry out periodic health screenings and outreach programs to proactively identify cases and encourage individuals to seek care at the treatment center. what would be the talking points? You want to tell them about Lassa fever transmission. You want to tell them about the etiology transmission, the symptoms, and what behaviors they can adopt to protect themselves and their family members. You want to address their fears and concerns about the use of health services. Are they afraid of isolation? Are they afraid of the, answer their questions, and then talk to them about household rodent control, and most very importantly, stigma prevention, because survivors come back to the community, and we've had instances where packed out of a particular compound because somebody who was treated and survived Lassa fever came home. So you want to talk to them as well about stigma prevention. Next slide, please. Then you want to improve access to diagnostic and treatment services. How can you do that? To help the community to make improve their use of the service and make them also bring them closer to the treatment center. You can distribute sample collection job aids to private clinics so that they're able to take quality samples that that the integrity will be maintained even to the point of testing. You want to establish community sample drop-off stations, especially for remote areas, and facilitate the transportation to ISTH. Case in point here, in this last outbreak, the acting CMD graciously approved that ISTH annex at South APA, they made a collection point. Now, Sapon West with the back roads is almost 4 hours distance from ISTH. And then we had samples coming from that axis, the donor axis, this challenge of being transported on time. But with the drop-off station provided by the ISTH treatment center, and facilitating that transportation of those samples directly to ISTH, that eased some of that pressure. Then you want to make sure that you have dedicated systems for result communication to the DSNO and health providers so that they can initiate contact tracing and transport confirmed cases to the treatment center. You want to ease patient admission into the treatment center, as well as collaborate with local government public health teams to track confirmed cases who do not report, probably because they've put phone numbers that have, maybe their phones are stolen or non-existent, or they have addresses that cannot easily be traced. Next slide, please.
All right, Dr. Ikaite, you have to wrap up now.
Yes, so you want to collaborate with the LGA teams, SMOH, WHO in strategic planning, collaborate with the World Development Committees, Village Development Committees, and participate in rapid response teams. Next slide. Next slide. And for the facility, you want to ensure that you have patient-centered care provided by staff of the treatment center, provide counseling and mental health support to patients and caregivers in non-stigmatizing environments, involve the family in the care of the patient, and if you can, financially assist indigent patients. This will give you better treatment outcomes and increased chances of recovery, positive patient experiences, greater satisfaction, and deepen trust in the health system. Patient feedback would lead to improvement in quality of care. You'd have a positive perception of the hospital and reduce fear of Lassa fever. Next slide. I think that's the last slide. So, in conclusion, Lassa Fever Treatment Center community linkages can improve index of suspicion, facilitate access to diagnostic and medical care for Lassa fever cases, promote community participation and ownership of Lassa fever control strategies, and ultimately mitigate the impact of outbreaks. And how do we do this? We have to define the community's needs, map stakeholders, identify obstacles, define objectives, plan and implement activities as I have listed, and periodically evaluate the outcome of these activities. Thank you very much for listening.
Thank you so
Next
much,
slide,
Dr.
please.
Ikaite. Thank you so much for presenting within the 20 minutes mark. Really appreciate, and quite a lot to unpack, and we can tell that we'll definitely bring all of you back again in one form or the other, whether for IPC or risk communication, whatever aspect. But thank you so much. So our next presenter, who is currently in another meeting abroad in Europe, will be making a presentation quickly before he has to go back. So that's Dr. Cyril Erame, director with the viral hemorrhagic department in ISTH or institute, sorry, a consultant physician and neurologist. Dr. Cyril Erame, you have the floor, sir.
Okay, I don't know, can you hear me, please?
Yes, I can hear you loud and clear. Please go on.
Okay, so I will be very fast. Sorry, I have to jump off to another meeting, a physical meeting where I'm making a bit of a presentation. So just bear with me. So can we go ahead, next slide, please? Okay, so my presentation is to look at the varied presentations of clinical presentations of Lassa fever. So Lassa fever, as we all know, is a communicable disease, which is communicable for the first 2 to 21 days after infection. The symptoms may occur 3 weeks following the first, for the first time, following the first Lassa fever virus infection. And the ratio of infections to disease is largely unknown, but the Lassa fever can cause asymptomatic, mild, moderate, severe, and fulminant symptoms. It may go undiagnosed and untreated in the general community, since up to 80% of the infections are asymptomatic. Let's move on, please. So the illness starts slowly with vague symptoms like fever, widespread weakness, malaise, headache, sore throat, chest pain, muscle pain, nausea, vomiting, diarrhea, cough, arthralgia, and back and abdominal pains, and back abdominal pain will follow after a few days. This can be similar to any other febrile illness, which are common in the tropics. However, 1 in 5 infected people may develop more serious symptoms. Let's move on, please. Next slide, please. Yeah. So most severe cases may present with facial edema. Some people can call it like a bull neck presentation. So they have these funny looking swellings on the neck. People have missed that to be a goiter sometimes. So they have petechial bruises, respiratory distress, hepatitis, renal failure, fits, tremors, altered gait, ataxia, disorientation, loss of consciousness, mouth, nasal, vaginal, or gastrointestinal bleeding, what is usually termed clinically as bleeding from body orifices. Again, in endemic locations, can consider alongside the febrile surgical acute abdomen and acute appendicitis. This is particularly important because it's a very high risk for health worker infections. Recently in Benin, there were 2 fatal cases which were managed by surgeons, one for appendicectomy, one had an appendectomy and one had a cholecystectomy. But the surgeons noticed very massive bleeding post-surgery and intra-surgery, and had to ask for a Lassa fever screen, which was positive. And the obstetricians will speak more, but please hold on. The obstetricians will speak more, but recently a lot of eclamptic fits and eclampsia cases have been related to Lassa fever. In fact, if you have that, you should look for Lassa, because most of the healthcare workers' infections who have been from obstetricians who operate in the view to save life, patients who they think have eclampsia. Let's move on, please. So complications, severe Lassa fever causes bleeding from the orifices, eyes, mouth, intestine, disseminated intravascular coagulation, fluid accumulation in the pleura and pericardial cavities. This we have noted in a study where we did a lot of abdominal general ultrasound scans and found this out. They could have spontaneous abortions, renal failure, multi-organ failure, hypovolemic sepsis-induced shock, encephalitis, encephalopathy. Encephalitis, more of inflammation of the brain parenchyma, encephalopathy, which is usually related to metabolic disturbance, usually, and most times, renal failure, uremic encephalopathy. And then they could have 8 cranial nerve deafness, amongst other symptoms. These traits are still poorly understood, but there's a lot of ongoing clinical research in that vein, and these are due to some mechanisms which we think most now is related to a kind of inflammatory response of the body, though it's not fully elucidated. Lassa fever often causes sensorineural loss, hearing loss, which is quite remarkable. The potential causes is auditory nerve spiral ganglion degeneration, cochlear hair cell damage, and immune-mediated systemic vasculitis. A third of infections cause deafness, typically irreversible, which is important because, and they could occur at any point of the disease. Other ongoing neurological effects include seizures, gait problems like ataxia, which have been reported, and tremors and encephalitis, which could be ongoing in patients. I will say that in the case I will describe. Let's move on, please. Next slide, please. So concerning mortality, only 1% of Lassa fever infections kill. Although a disproportionate percentage of hospitalized patients died, within 14 days, 15 to 50% of hospitalized patients died from the condition. Pregnant women, children, people with HIV or other immunodepressive diseases like diabetes are more likely to die. Suboptimal management of hospitalized patients can cause acute renal injury, liver failure, encephalopathy, seizures, reduced consciousness, DIC with mucosal bleeding, septic shock. All this can lead to multi-organ failure and mortality. According to research on Lassa fever epidemics in Nigeria, individuals with acute renal failure, encephalopathy, shock, DIC, and bleeding have increased mortality. So all these are what we have tried to do in Irrua to intervene to improve mortality. And shockingly, introduction of dialysis has improved mortality, and recent times we have also introduced hematological care, improving hematological care, and also improve respiratory support. So it's important to say at this point that in the management of Lassa fever, a transdisciplinary approach is quite important. Next slide, please. Oh, there's no next slide. So I'll just talk about some unusual cases, which for time's sake, we might need to go check up ourselves. So you can have a good read of an acute abdomen presenting as Lassa fever. Don't go at all. Just check Google. Don't go at all and Lassa fever. You find that. And then there's a paper between me and Professor Kokiri, which I'll talk a bit about. And then also there was a case of delayed onset paraparesis, which was reported at Owo by the Alima team, Duvinod. And then Ezioma et al. Also reported post-cerebral ataxia in a patient who had Lassa fever. So I'll just talk a bit on the case which we saw in Irrua, which was quite interesting, quickly in the next few minutes. So it was so it was the case about the Lassa fever encephalitis is published in case reports in neurology in 2018. The paper name is acute Lassa virus encephalitis with Lassa virus in the cerebrospinal fluid, but absent in the blood. Striking. That was also been reported by Gonta et al. In Germany, a case report with a positive outcome. So there are so many interesting things about this case. It was about a lady who came around the period of December after Christmas with a history of fever, and then for which it was thought she had a bit of malaria. And then she was treated for malaria and went back home and came back 5 days later, now with irrational behavior. And then I was called as the senior registrar in neurology then, and I saw, and because of a high index of suspicion, despite the fact that Lassa PCR done was negative, I started her on ribavirin. But the next day, a cerebrospinal fluid CSF collected was positive for Lassa, and she was still negative for Lassa in the blood. She improved quickly after treatment. But other striking points about her was that her sister also had a febrile index, though not diagnosed, which was complicated by sensory neural deafness, and they were identical twins. And so it showed the pointer to possibly trophism for CNS in some persons, maybe in host susceptibility, and also relativeness to some virus stain in the site, centralized site for some point. But all that we could not fully elucidate because the investigation was difficult. But also another important thing was the period where she came, which was in December, and then the high index of suspicion, which I had to start her on ribavirin. And that saved her life, and it made us a good case report, which should be an unusual presentation, which we should look around in endemic patients in that area. Others were the ones which I have mentioned. So in summary, I've just tried to quickly talk in the last 10 minutes about the varied presentation of Lassa fever, but what you see commonly and what could be seen as complications and what can be seen as unusual cases. Thank you, and then hope you got something out of what I said. Over.
Wow, thank you so much, Dr. Cyril Erame. Thank you for that wonderful presentation and doing it in way less than the amount of time you were supposed to do the presentation. So thank you so much, and we understand how busy you are, but whatever question we have, we'll also direct at you. Please don't leave us. I know you're going to make a physical presentation. Just stick around. We'll still have a question and answer session after Professor Okogbene's presentation. Okay, so Charity, I think the next presentation is that of Professor Okpukbeni, not this one. So
Thank
Charity,
you.
all right, thank you. So the next one is that of Professor Okpukbeni, the former CMD of ISTH, and currently he's in transit, I think in Paris, if I'm not mistaken. And we actually moved the presentation following our discussion yesterday to the last presentation, hoping that he'll be able to meet up. But unfortunately, I think he's still probably dealing with customs at the moment, or are still in transit. We don't know the situation at the moment, but we know he's in transit. So we haven't been able to reach to him, but we believe he's fine. So Dr. Joseph will be making this presentation on behalf of him. Charity, what's going on, please?
All right, thank you very much.
Yes, so sorry, your presentation will be shared soon. So this presentation will be on managing hospital outbreaks or healthcare workers' infection and consent in vulnerable populations, so pregnant women, children, and the elderly. So on behalf of Professor Okpukbeni, Dr. Joseph is making this presentation. So over to you, Dr. Joseph. And you have 20 minutes or less if you can, because we are running behind schedule. Thank you.
All right. Please let me know when I'm about 15 minutes into the presentation.
All right,
Professor Okpukbeni is unavoidably absent. He personally designed this slide himself, and unfortunately, he's still on transit for another very important Lassa program in Paris. So I'll do a quick presentation using the slide he has presented. I'm happy that this presentation is coming at this time, because this is one of those times that you have a build-up to another set of outbreak of Lassa fever. We understand that oftentimes we have seasonal outbreak. Although the Lassa fever has remained an epidemic occurring all week, all year round in Nigeria, but there are specific seasons when we have a surge, usually around the dry season. And it's important we are having this now for us to see some, unique clinical features we can also look out for, and also to create more awareness, so that this awareness can raise the index of suspicion, particularly by primary caregivers, not just the doctors, not just the nurses, but everybody that works within the healthcare setting, both tertiary, comprehensive health center, and primary healthcare facility. This is very key. We understand that Lassa fever is a viral hemorrhagic fever and affects all cadres of persons. It affects adults, it affects children, it affects both pregnant and non-pregnant population. It has its own peculiarities. And then there's an important entity we also need to understand about Lassa fever. This has to do with the primary caregivers. Because we have mentioned over the years that, hello? Okay.
I can hear you, please go on.
We have mentioned over the years that all healthcare workers have to be protected by all means possible, because we need the healthcare workers to be alive for us to be able to prevent and manage this disease. So this is very key. This is very key, and is an important aspect of our presentation. You can move on to the next slide. Now, there are a group of people who call vulnerable population: the pregnant patients, the children, outside pregnant women, outside the elderly, who are also vulnerable to having this infection. This group of people are the healthcare workers. They are particularly vulnerable because they are usually at the first point of care for this patient. Before the diagnosis are made, these are the group of people, these patients, visit. So it's important that we understand the peculiar presentations of Lassa virus disease for those who work in primary healthcare setting, in private setting, and in tertiary healthcare setting. This is very important. Lassa fever in pregnancy is associated with high morbidity and mortality. We understand that the general morbidity and mortality statistics for non-pregnant adults ranges just between 15 to about 21%, although some papers have reported a mortality index of as high as 35% for non-pregnant population. But oftentimes when you go to literature, it's usually not more than about 30-35%. But in pregnancy, you see that the mortality rate is usually very high, ranging from about 35 to 65%. Some have recorded up to 80% in early studies that were done in some countries like Sierra Leone. Now, one will wonder, why do you think Lassa fever the mortality from Lassa fever is so high in this group of very vulnerable population? One of the reasons that have been attributed is the peculiarities in these patients, the peculiar presenting clinical signs and symptoms in this group of patients. You understand that a pregnant woman who is having an abortive process, bleeding from the vagina, if a healthcare practitioner seeing that particular patient does not have an index of suspicion which is high for Lassa fever, the first thing that person thinks about probably would just be an abortive process, a miscarriage. That's one of it, which will eventually delay the need to order for a test for that particular patient. And then we also understand that the pregnant population have other peculiarities. Some of them have some level of suppressed immunity during pregnancy. And we also understand that the Lassa virus have predilection for fetal tissues and then some aspects of the placenta, which makes them harbor more viral load in pregnancy than in non-pregnant population. So oftentimes you find that pregnant patients may present with higher viral load as we find in non-pregnant population. And you know that higher viral load often correlates with poorer outcome. So what do you have? Increased morbidity and mortality. The perinatal loss rate is also very high. Some have reported a perinatal loss rate of over 100% for same reasons, you know, either from delays in making some of these diagnoses, you know, or it may have come from late diagnosis from the mother, you know, during the perinatal period. Perinatal period usually runs from the period of viability after 28 weeks of gestation up to when that baby is delivered. So the perinatal loss rate can actually be very high in this group of people. So these are some of the reasons why it's been said that the pregnant woman needs to particularly be protected at all costs. Apart from this, the pregnant patient is also very important because a couple of healthcare workers may be exposed to one particular pregnant patient. You can imagine a pregnant patient presenting into Lassa ward, where people have presenting to the labor ward, where there's a very low index of suspicion. If that patient comes out positive, you can imagine the number of healthcare staff that will get infected in the process of either trying to manage that labor or try to manage some of the complications which this patient has come in with. In the last outbreak, we had a couple of atypical presentations. Some of these presentations include eclampsia. Some of these patients presented with fits the first time they were coming, but before they were referred to the hospital, you know, we had other ancillary investigations done, which turned out positive. A couple of other healthcare workers have been exposed at that particular point in time. Outside that, hemorrhage, unusual bleeding, vaginal bleeding, bleeding after childbirth, which was interpreted as postpartum hemorrhage. So we have a couple of challenges, even with surveillance, having to go back to these areas to see that the healthcare workers who were exposed are properly, looked after, proper contact tracing, to see that they don't don't come up with health-related infection from exposure to these pregnant women. So it's important that we understand these peculiarities that are associated with it. So history is very key. Physical examination is very key. Another ancillary investigations you would do, when you are taking some of this history, the patient may have complained of having fever, or the patient may have had an unusual adverse event. A patient may have a missed abortion, which you cannot explain. A patient may have an intrauterine fetal demise, which is difficult to explain what has actually caused it. This patient is not hypertensive, is not diabetic, has not had an adverse pregnancy event before, but he may give you a history that he went to a hospital where he has taken anti-malaria, he has taken paracetamol. At the point that patient is presented to you, is no longer febrile. These are some of the complaints they may be giving to you. And some of them who come with typical physical presentation, you can see some of them, either coming pale, with anemia, or they're having what we call breast engorgement. The breast become full, the breast become engorged. There's no breast mass. There's no expressible breast milk discharge. It can be unilateral. It can be bilateral. It could also be very tender. In fact, that's one of the unique clinical features you could find in many pregnant women with acute Lassa virus disease. These are common in many cases of these patients who have Lassa virus disease. We understand the modes of transmission. We have already discussed this. I think Dr. Tobin has talked about it. But these unique clinical presentations are things we really need to look at, particularly in this pregnant population. And that also applies to children. Can you go over the other slide? Can you move on to the other slide? Yeah. For healthcare workers, doctors, we understand that doctors, nurses, and other healthcare workers providing direct care are at risk. We understand that, we understand the level of precaution, what we call universal precaution, that we must apply to many patients we don't know. But we understand what happens in many areas where we practice. Even in major tertiary health institutions, these standard precautions are difficult to maintain. Than when you go to core rural communities, they are almost not there. When you get to core rural communities, you are no longer having nurses, you're no longer having doctors. It's difficult to find a doctor in many core rural communities currently. And most of these patients are left in the hands of poorly trained, not really trained nurses, either those who have trained somewhere which they now call, in quote, auxiliary nurses, or traditional bed attendants, or some chemist attendants who really did not have this, have not been trained to proficiency to understand how these clinical signs and symptoms would look. So what do you expect?
Sorry, Dr. Joseph, you have 5 more minutes. Thank you.
Yeah, so you have a couple of healthcare workers being infected with the viral, the viral hemorrhagic fever. So it's important that we understand some of these things and then make efforts and then do more to do training and retraining, not just within the tertiary healthcare setting. The focus at this time shouldn't be at the tertiary healthcare setting, but we have to start going down to the comprehensive health center, going down to the primary healthcare center. A couple of referrals come from the private hospital. It's time to start going down, doing step-down training. You have to understand some of these things because it's still going to come. So long the vaccine is yet to be available, we are still going to be having seasonal surge of this Lassa virus disease. And I think I'll quickly end here, but I want to quickly mention that we, as the Institute of Viral Hemorrhagic Fever and Emergent Pathogens, we have the capacity to do a couple of things. And when you are sending your sample, once it gets to us, our turnaround time is usually within 24 hours. And if you have very high suspect cases, you feel you can't even manage in your center, we have the capacity, even capacity to help. You can deploy technical staff the institution to help you deploy some, to help you, move some of these patients to the isolation ward where proper all infectious morbidity like yellow fever, dengue, and other viral hemorrhagic fever. We also have the capacity to screen them. So we do a couple of things here, and we're always willing, to assist when the need arises to actually do so. Thank you very much.
Oh, thank you so much, Dr. Joseph. I've never seen someone present a slide that was not prepared by them so professionally, so apt. Thank you so much, even at the very dying minute of reaching out to you and sending you Prof's presentation. Thank you for making a world-class presentation from his slide. And I'm sure he'll be very, very proud of you. So I think this takes us down to the treatment center readiness. Please share, yes. So I just noticed, okay, Professor Robinson, thank you so much for taking our time to prepare this slide and make a presentation on behalf of the other Lassa fever treatment centers. So you actually have 5 minutes for this presentation, and I'm just hoping you just give us, how do we make it better? What was your last outbreak experience and how do we make it better? So if you can quickly just do this 5 minutes and then we go into the question and answers and wrap this up because we're already running way behind schedule. Thank you so much, Prof. Over to you.
Thank you very much. I want to thank everybody who has joined. Professor Robinson Chukwudiono, the CMD of Alexei Kweme Federal Teaching Hospital, Abakaliki, Ebonyi State. My outline is as stated here. As a way of introducing, the issue of Lassa fever in our center has been something that started long ago, since 2005. And we had series of experiences. The worst of it is that initial period, the experience of losing our healthcare workers. And at the same time, because we had nothing then, we have to move all the way from Abakaliki to Irrua for diagnosis and sometimes for treatment. But today, we have what it takes to diagnose and manage. And I want to share our experience just within the last months, starting from January to date, because of time constraints. So looking at this month, last month we just ended, we had a total of 11 cases. Out of that 11 suspected cases, only one was confirmed, and that confirmed case eventually didn't make it. Reason being that there was late presentation. So our experience is that we still have high case fatality rates, because for that month of October, we had a case that was confirmed, and we also had a mortality that occurred in that case. And incidentally, it was a pregnant woman. Every effort was made to see what we can do to ensure that she survived, but somehow, because of late presentation, she didn't make it. I can't see my slides. Hello?
Okay, so I think they are up now. Sorry for that. Can you see them now?
All right. Yeah. Thank you very much. I can see them now. Just go back to the first. Can you go back? Yeah, beautiful. Thank you. So starting from January to date, we had a total of 338 suspected cases, and 54 was confirmed. Of course, the remaining were not case confirmed. They were negative cases. And we've had 31 deaths giving us a case fatality rate of 57.4%. To us, this is not acceptable. But the problem from our experience has been late presentation. Most of the time, our cases don't come early. They have to go from one chemist shop to one private hospital to one primary health care, secondary health care before they finally get to a hospital when they are very bad. Like the last case I talked about, he came like an eclampsia, and before you could know it, he couldn't make it. So that has been our experience, late presentation of cases. Next slide. So this is a picture of what has happened over the year. You could see that we still maintain the peak period within those dry seasons. So we're looking at December, January, February, March. That's when we have a lot of cases. Incidentally, the other remaining part of the year, they are not free. But when you look at the slide, you will notice that week 27, 24, 28, and week 40, we had 100% mortality because these cases present late, and before you could make your diagnosis, within 24 hours, you'll have mortality. And that is our experience. What we think we should also see what we can do for them to present early so that we can survey the situation and reduce the case fatality rate that we have. Next slide. Next slide. Thank you. Yeah, so from our experience, we've also noticed that in Ebonyi State, there are areas where these cases come from. So when you look at the 13 local governments, out of 13, cases came from the 9 local governments, which tells us that it's almost everywhere. So we have at least one confirmed case coming from 9 local governments in the cases that we had over the last 11 months or 10 months. And out of it, 6 were pregnant women. And like I've told us, most of these pregnant women, they present late, and they result in the death of the woman and death of the baby. So we also have progressed. Within the hospital and within the health workers, there has been increased IPC. And because of that, no health worker actually gets infected. 10 months, what we've had is health workers who possibly developed fever and felt it was Lassa, but by the time we did PCR, because we have a functional PCR machine, we could identify that it wasn't Lassa, but psychologically they were affected. So, but there has been improved IPC within the hospital setting and within the health workers that manage these cases. Next slide. Next slide.
So you have just 2 minutes to wrap up, Prof. Thank you so much. Hello, Professor Robinson. Can't seem to hear you. Or is it my network? Okay. Looks like Professor Robinson has been kicked out by the network. Charity, can you go to his last slides? I think we just have to probably stop. Okay. The best practices. Okay, so I think we'll just have to go to the question and answer session. Unfortunately, he could not actually finish making his presentation. I guess that will be the network kicking him out. Okay, Dr. Lois, over to you, ma'am, for the question and answer session.
All right. Thank you so much. This is actually to appreciate. Can you confirm if
Sorry.
you can hear me, please? Okay.
Okay, I should
Prof, if you
conclude
can just finish your
because of
presentation.
time. All right, and
sorry,
network
Doctor.
also.
Yes,
Well,
please just
as a way of
conclude.
concluding, we still notice that the peak week for Lassa in our place still remains the first 1 to 12 weeks of the year. But from what we've seen, it can still occur anytime within the year. So because of that, we have to mount surveillance towards the early detection. There are still high case fatality rates, which occurs off those peak periods. So we have to see what we can do to reduce that. Of course, the mortalities were mainly due to late presentation. And there has been improved IPC. Because of that, health workers actually don't get infected again. The next slide. So we want to recommend that there should be increased risk communication and community engagement by us, the state team. And we need to also sensitize the private, the mission hospitals and patent medical medicine vendors and chemists so that they will be conscious of the symptoms that should make them to refer these cases. Then we also have to keep continuous training of the health workers. Cage within 13 local government areas, and of course, enforce early referral to our hospital. So we are also planning that there should be support of the primary healthcare centers, looking at with our partners and with the state team. Then we have to also sustain sensitization of health workers on IPC measures so that we don't get back to health workers getting infected. We also have to sustain what we have been able to do in reducing the test turnaround time so that we can always get our results within 24 hours. Next slide.
All right, thank you so much, Prof. Thank you. Like, it was a very tight one. I knew it was almost impossible.
Well, let me acknowledge NCDC, WHO, MSF, and everybody who.
All right, thank you so much. We
Thank
really
you.
appreciate, despite the network glitches and the very short time as well allocated. Thank you for making this presentation on behalf of other treatment centers. Thank you for taking our time to prepare the slide, despite your very busy schedule as the CMD of your teaching hospital. Okay, over to you, Dr. Lois, for the question and answer session.
All right, thank you so much, and actually to appreciate all the speakers actually for sharing their experience with us. I'm sure we all agree with me that this first of the webinar series is actually relevant and it's coming at the very right time, and this is to ensure that, as been mentioned by the department, to ensure that we have a one-digit case fatality rate in the country. And one of the ways of doing that is to ensure that we have a high index of suspicion, and then we have early reporting to health treatment centers, and we have a good relationship with the communities where these cases are actually emanating from. So we'll go and answer time, but I want to plead with us. We don't have so much time, and I know we still have a lot to do. So we'll just go take some of a few of the questions, but I want to implore you, for those who may have other questions and maybe our questions are not answered in this session, as has been said, this is just the first of the series. We're definitely going to have another session very, very soon. So if the questions we are not answered in the regular one, please let's take note of them so that when we have the second one, we will ensure that we address the questions. So the questions are not really, addressed to any particular, presenter, apart from one that is addressed to Dr. Ekaite. So any of the presenters can actually, respond to that. So one question is, if you find out if a root cause analysis has been done to elucidate causes of healthcare worker infection. especially at maybe at Irrua Specialist Kitchen Hospital or any of the treatment centers that is on this call, if any root cause analysis has been done to elucidate the causes of healthcare worker infection. That's the first question. And then there is a question from the former CMD of University College Hospital Ibadan, who wanted to find out if about the staff unilateral flow in shower, if before staffing the patient management area. Is that what's the, you read out exactly the way you wrote it, what's our plan, or what do we think about that staff unilateral flow and chlorine shower before staff exiting the management area? And as I said, this was actually done in UCH. At the time, it was the CMD, and there was no healthcare worker infection over 8 years. So what's our experience over that from any of the, any of the speaker can actually respond to that. And also, I don't know if you have any IPC focal person on the call or from the treatment center, and to find out what has been done to improve IPC implementation at healthcare facilities in order to prevent healthcare worker infection. So these are the questions from the members of this call. So I don't know, any of the speakers can actually respond to that. And the one addressed to Dr. Ekaite specifically wanted to find out what is the practical way of identifying the community's felt and actual needs. What's the practical way of identifying the communities felt actual needs? And so please, I'll plead with the speakers to actually, just go straight to the point so that we can wrap up as soon as possible. Thank you, and over.
All right,
so any of the speakers can
Dr.
respond to this.
So with regards to the IPC questions, I think we will not need to answer them here because this was actually focused on case management. Hopefully our next presentation or our next series will actually do the IPC one. We're already discussing with IPC pillar to make sure we have this. And I'm happy to see a lot of questions being raised in this area. So my colleagues from IPC, Dr. Tochi, Obiora, and team would have been listening and seen a lot of questions. And I'm sure in our next session, which will be focused on infection prevention and control, we'll be able to answer most of these questions. So over to you, Dr. Ekaite, for your answer to the question posed at you.
Yeah, thank you very much. So to identify the gap in the community, the needs the community has, both the felt needs, what they think are important to them, and what the real needs are, what is really important in bridging the gap between taking them closer to Lassa fever control. We want to do key format interviews. You can talk to the local government PHC coordinators, the DSNOs, hold key format interviews with them, with heads of organizations that work like WHO, that work at grassroots level. You want to look at surveillance data. So because you're trying to define the felt needs, so talking to the community leaders, talking to the PHC coordinators, talking to people who are there, who have knowledge of the community, who have knowledge of who are influential, who the community listens to, who the community speaks to. Then you want to carry out mini surveys. Sometimes we have medical students going out to these communities for their community health postings, and they collect this data, and you're reviewing this data, both published studies and great literature from student projects will also define what are the felt needs and the real needs of that community. Then you have data from the National Demographic and Health Survey. It will tell you the age strata, the social strata, the age groups, the health literacy, literacy rates, and all those health-seeking behavior. These are all factors that point to how the community feels about Lassa fever and how they use health services, not just the treatment centers, but health services in all. You also want to look at information data, surveillance data from structures like organizations like NCDC. So looking at NCDC data from CDC, pulling all data together, that is how you're going to be able to achieve, unravel the felt and real needs of the community. Thank you.
Yep. Thank you so much, Dr. Ekaite, for that. I don't know if any of this I know a lot of questions from this first series of the webinar is actually based on worker infection, and as been said by the Dr. Abioye, that we're planning towards having a session that will be dedicated to IPC. For those IPC questions, we may not answer them on this one, but the next one, just be assured that they will be addressed in the next series of the webinar. But I don't know if any of the speakers also would like to say one thing or the other before close up.
All right, Prof. Robinson, do you have any final words? Professor Ifedi? Okay, so I think there are no comments with regards to the other question. I don't think there's any other question though that has been left out. There is no IPC related, ma'am.
Okay, so the other question I have is actually which is EBC, and that is on the plan to support the treatment centers Thomas implementation. And I'll respond. I would like to respond to this that yes, at the moment we have data clerks who have actually been supporting treatment centers, been supporting some of the treatment centers. But I'd like to say that it is one of the our priorities at the moment is to ensure that we have summers before the treatment centers across the secondary and tertiary. And I know that the treatment centers are actually situated within tertiary facilities. So it is a major priority for the NCDC at this and NCDC at this point actually across these facilities. And I'm sure that in the next 1 or 2 or 3 weeks now, this some will be deployed, and then we'll start with the first series actually of summer deployment. I know we met with the committee of CMD sometimes ago, where we introduced the plan to deploy summers, in the health facility. So they're already in the know, but actions will actually start that. I think we're starting with a number of 6 or 8 at the moment, is to ensure that we cover all the all the facilities, secondary and across states and the federal capital and the federal. And also the other one is the research priorities on Lassa fever in country. So there is a research agenda actually for Lassa fever, and in one of the sessions will also be dedicated, towards research. And also that we also have another session that will be dedicated, towards surveillance. This is one of the aspects. This is case management. As we have said, there will be a session on IPC. There will also be a dedicated session surveillance and reporting of suspected Lassa fever cases. So I'm sure we all agree with me that this cannot be a one-off thing. It's actually going to be a series whereby we ensure that we cover all the aspects, of this as much as possible. So I guess that will be, that will be all. And if your question has also not been answered, you can also, in the other series, we'll also ensure that we capture them. Just take note of them so that we can actually address them in our other series. So I guess that that will be all for the Q&A. And I think we can just move on to the closing, right?
Yes, thank you so much,
do you have
ma'am,
anything
for
to say, or we move on?
facilitating that. No, so we now go to the close conclusion and wrap up by Dr. Ladun Kuromade. Thank you so much.
Okay, so Dr. Ladu has not been able to join again because as we are all aware, we are also responding to diphtheria outbreak in the country, and it's actually involved a number of states. So there's been a lot of programs and activities, in that wise. So that's why she has not been able to, to rejoin after giving that opening remarks. And so I'll be giving that closing remarks on her behalf. And so this is actually to appreciate everybody actually for joining this first webinar series, which is titled "The Risk for Lassa Fever Outbreak in Nigeria and Improving the Index of Suspicion for Lassa Fever." And the first appreciation on behalf of the head of department goes to all our speakers, for sharing the experience, for taking time out of their very, very busy schedule to share the experience with us on how they've been managing and controlling Lassa fever cases, in the centers. And I'm sure this experience is invaluable, and I'm sure that we've all been able to get one, and which will guide us in our, in our state of preparedness and response to Lassa fever in the country. And as we have said, this initiative is actually part of our ongoing efforts to prepare and strengthen our response to Lassa fever, especially in eye-burden areas. So once again, a special thanks to Irrua Specialist Teaching Hospital for sharing their valuable insights with us, and also for the participants who have taken time out of their busy schedule to actually join this. So one of the things I would like us to take from this note is that from this webinar is the fact that it is crucial that as healthcare workers, recognize the signs and of fever as early as possible. It has been experience share from Irrua, early being one big rate. So it can definitely improve further. Also, it needs for us to closely, with infection and control teams to be able to measure, break this chain of transmission within the healthcare facilities as well as surrounding communities. And as we do our work, please let's ensure that we take care of proper protocols and practices, which are essential, because we do not want to record any case of healthcare worker infection or health facility. And so that readiness and collaboration stakeholders, they're very, very, and by enhancing our index of suspicion, improving IPC, ensuring timely diagnosis, we can make significant strides in controlling. And so I encourage everyone, knowledge and experience and insights that we have gained this back to our respective institutions together with Nigeria, and then protect the health and well-being of these. So before I close, I know one of the comments shared in box is the need to ensure that we capture all workers as much as possible, and with the time, that for this one, many of them may not have been able to join. So we've taken note of that, and we'll consider that in our next series. So once again, thank you, and and we achieve the fatality rate is actually commendable. So let's continue our collaborative efforts to ensure prepared and we're better equipped to handle Lassa fever outbreaks. So as we go, please let's stay safe, and until next time, thank you so much for coming. Enjoy the rest of the day. Bye.
Thank you so much. Thank you, ma'am, for that wonderful closing remarks. So our next session will be in hopefully 2 weeks, but this is going to be a series that will run until January. So please keep looking out for more of these sessions targeted at the different pillars or aspects of management and control of Lassa fever. Take out time to fill the attendance sheet before you leave, and also take out time to also fill the evaluation for the workshop. Until we see you again next time, hopefully in 2 weeks' time, hopefully, fingers crossed, and we'll have a much better and organized presentation, and also enough time for question and answers. Thank you so much, and bye for now. Have a wonderful week as well. Bye.
Thank you. Bye.